structure. These antibiotics are most commonly used as a fallback or as an alternative to the treatment of group A streptococcal and pneumococcal infections in patients who have penicillin allergies. They generally work by inhibiting protein synthesis in the bacterial cell by binding to the 50S subunit of the ribosomal structure. We have 5 examples of macrolides, and the commonest one of them are erythromycin, azithromycin, and clarithromycin. The 2 other examples are roxithromycin and spiromycin. So for you to remember the examples of drugs in macrolides, you can use a mnemonic CARES, C for clarithromycin, A for azithromycin, R for roxithromycin, E for erythromycin, and S for spiromycin. While looking at the mechanism of action, macrolides mainly work by binding to the 50S subunit of the bacterial ribosomal RNA, which in turn interferes with the bacterial protein synthesis. This binding is near the peptidyl transferase center, and it actually prevents transpeptidation process by blocking the polypeptide exit channel in this ribosomal function. As a result, the peptidyl transfer RNA is dissociated from the ribosome. Macrolides are known to be bacteriostatic. However, in higher doses, macrolides can become bactericidal, or they can kill the bacterial cell. But looking at the examples, we will maybe focus on the 2 commonest examples, erythromycin, azithromycin, and clarithromycin. Azithromycin, to start with, is a type of macrolide that has a similar spectrum of activity, coverage, and the mechanism of action as other examples. Azithromycin is known to be active against Mycobacterium avium complex and Toxoplasma gondii infections. This drug is quite highly active against Chlamydia species, and it differs from erythromycin and clarithromycin in its pharmacokinetic properties. It is known to penetrate most tissues very well except the cerebrospinal fluid, and this drug is slowly released from the tissues, making it have a tissue half-life of between 2 to 4 days. This one makes it unique, permitting a single dose daily dosing, therefore shortening the duration of treatment in many cases. Azithromycin is rapidly absorbed and well tolerated orally as compared to other macrolides, and we always advise that these drugs be administered 1 hour before meals and 2 hours after meals. The presence of an antacid, such as aluminum and magnesium antacids in the stomach, do not alter the bioavailability of azithromycin. However, they can delay absorption and reduce the peak serum concentrations. And lastly, azithromycin does not inactivate the cytochrome P450 enzymes. Another example of macrolides is clarithromycin. Clarithromycin is a derivative of erythromycin by addition of a methyl group to the azithromycin structure. It has an improved acid stability and a good oral bioavailability and oral absorption. This clarithromycin is more active against Mycobacterium avium complex as compared to other macrolides, and it basically has a moderately long half-life of about 6 hours, therefore allowing 2 times daily dosing. Clarithromycin penetrates most tissues very well with concentration equal to or exceeding the serum concentration, and generally is metabolized in the liver, and the active metabolite has an antibacterial activity. Some partitions of this drug are eliminated in urine, and therefore in patients with renal impairment we will need to alter the doses downwards. And generally, clarithromycin has a lower incidence of GI intolerance and this less frequency dosing, which actually is important in reducing the GI disturbances. Pharmacokinetically and pharmacodynamically, macrolides are destroyed. Macrolides, basically erythromycin base, is destroyed by acid in the stomach, that is hydrochloric acid. This means erythromycin is usually administered as an enteric coated tablet. They're relatively poorly absorbed orally, and food interferes with the absorption of most macrolides. Renal adjustment for renal failure is not really necessary in erythromycin. And remember, erythromycin is not dialysable. Large amounts of the administered dose of erythromycin are excreted in bile and then lost in feces. The absorption, like we have mentioned before, is distributed widely into body tissues except in the brain and CSF. And erythromycin is known to traverse the placenta. Erythromycin is known to traverse and cross the placenta, reaching the fetus. Some of the common side effects and adverse drug reactions that are experienced by macrolides can be remembered with a mnemonic macro. M stands for motility receptor stimulation. They are for producing GI-related effects, for example, anorexia, nausea, vomiting, and diarrhea. Most of these macrolides. Remember, macrolides are direct stimulants of gut motility. The A means arrhythmias or QT prolongation. Another side effect is cholestasis. In cholestasis, macrolides are known to produce acute cholestatic hepatitis, which tends to recur if the drug is re-administered. Then we have rashes, covering the term for allergies and allergic reactions, for example, fever and eosinophilia. Then ototoxicity can be present in these patients, however, it's a reversible ototoxicity. Erythromycin metabolite inhibits P450 cytochrome enzymes and therefore increase the serum concentration of numerous drugs, including theophylline, warfarin, cyclosporin, and methylprednisolone when they are administered concurrently. Erythromycin can increase serum concentration of allodigoxin and should be administered cautiously in patients with heart issues and those on digoxin.